Welcome to today's ECG webinar presentation titled Pediatric Provider Performance in a Value-Based World. In this webinar, we will review trends in children's healthcare and pediatric physician compensation, as well as summary findings of our 9th annual Pediatric Subspecialty Physician Compensation Survey. The survey findings are drawn from responses from more than 7,300 pediatric subspecialists at 48 of the nation's premier children's organizations across the country. Hi, I'm Maria Hayduk, and I am a Senior Manager with ECG, and I'm pleased to be your host for today's webinar. Before we introduce today's speakers, let's go over a few details about the webinar. It is 60 minutes in length, and the first 50 minutes of the program is a presentation followed by a 10-minute question and answer session. Everyone should have received a copy of the session's handouts, but if you're a late registrant, you can download the handout in the handout pane on your screen. Note that attendees are participating in listen-only mode, but if you have questions, you can type them into the question and answer pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, our speakers will answer as many of your questions as possible. Finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete that survey. And for each survey completed, ECG will make a $5 donation to Doctors Without Borders. Now let's meet our today's speakers. Our first speaker is Ken Rorda. Ken leads ECG's Children's Hospitals practice. Having worked in healthcare planning and operations since 1991, Ken has significant experience working for children's hospitals, academic medical centers, pediatric programs, faculty practice plans, and other pediatric physician organizations. His work spans strategic and business planning, development of affiliations and other physician-hospital relationships, and topics related to physician group practice formation and operations improvement. Welcome, Ken.
Thanks, Maria.
Our next speaker is Angie Collins. Angie is a manager with ECG and is responsible for conducting and expanding ECG's Pediatric Subspecialty Physician Compensation Survey. She also plays an integral role in conducting the National Provider Compensation Survey and other proprietary research efforts in the firm. Angie's expertise has been instrumental in expanding ECG surveys, which are now recognized as the most comprehensive source of provider performance benchmarks in the market. Welcome, Angie.
Thank you, Maria.
So let me talk a little bit about the program today and our agenda. I will be going through a brief introduction to ECG and our surveys. And Ken is really going to lead us through the trends in children's healthcare and the pediatric physician compensation environment. And as an expert in the market and someone who is out there consulting in children's hospitals all the time, Ken brings a wealth of information to these topics and really will give us an update on what has been happening out there. And I'm sure many of you will relate to much of what he has to say today. And then Angie will present key findings from our Pediatric Subspecialty Survey, really getting us into some of the data and what are the things we're seeing analytically that we collected in our survey and that we're currently studying and really beginning to think about, how these findings impact our consulting work going forward. And before we get to your questions and answers, Angie will give a highlight of our ECGVault, which is our online benchmarking tool. So as we move on to the introduction, I'll remind you a little bit of who we are as a firm. At ECG, we focus solely on healthcare, and within healthcare, really these 4 disciplines: strategy, finance, operations, and technology. The children's practice, which Ken leads, touches upon all 4 of these competencies. The proprietary research practice, which Angie is part of, is what produces our surveys, and the pediatric survey being one of those studies. And the study really goes to support much of the work we do in the firm in terms of really gathering unique market information and information we bring to bear on all of our projects, and we just feel, make us better as a firm. And with our surveys, we have 2 annual studies that are national in scope. Our physician compensation survey, which we've been doing for 16 years, and our pediatric subspecialty study, which Andy will highlight the findings today. Those 2 studies combined contain data, provider performance data for nearly 35,000 providers from 111 provider organizations across the country. The pediatric study has more than 7,300 providers from 48 pediatric providers organization. Our CPT code profiler is a tool that we offer to our clients that contains the CPT data from those 34,000 providers, and allows organizations who subscribe to it to really understand the practice patterns of physicians within each specialty. So it allows them to look at what their coding profiles are by specialty or even by provider, and see how they compare and whether they're doing anything unique and whether something needs to be addressed. Our National Medical Group Cost and Staffing Survey, we just wrapped up our 2nd annual study, and that's national in scope as well, and it's mainly a large health system, large independent medical group study. And then we do various other custom surveys, which our clients reach out to us to design and execute around, maybe national or regional market trends that they're interested in understanding better, and they reach out to us to conduct a custom study. So without further ado, why don't we hand it over to you, Ken?
Thanks, Maria. Appreciate that introduction. And I'd just like to spend a few minutes at the outset here. I know many of you are very interested and anxious to hear about some of the specific survey results, those of you who've joined our webinars in the past in particular. But we do like to spend a few minutes just setting the context within which to review these findings from the survey itself. And these are based on our take of the market, our consulting experience, but really have direct application, I think, to some of the results that Angie is going to share with in the middle and latter part of this presentation. To start with, on the slide 8, there are 5 trends, basic trends, that we want to highlight. The first is the rise of consumerism, increasing focus on population health, which, of course, many of you, if you've tuned in to us in the past, you know that that's been an ongoing trend. The influence of larger systems on pediatrics specifically. So this is a very pediatric-specific trend. The measurement of return on technology investments, and then finally, emerging cost containment pressures. I'd like to spend a few minutes talking about each one of these trends. The first trend, slide 9 in, is the rise of healthcare consumerism. And this essentially, as I know many of you are aware, encompasses the moving beyond the core measures of quality and the emergence of third-party watchdogs around quality and quality of pediatric care in particular, and the need for transparency. So consumers increasingly, through their health plans or just on their own, are seeking out these results and these measurements. And as a result, this industry is kind of moving forward. Of course, it's naturally very difficult because we're talking about smaller patient bases and uniquenesses of diseases and conditions. However, we see this as an increasing trend, and it's forcing our clients to become better at measurement and then focusing on how to improve their metrics. The second is around price, and I'll speak to a moment later about cost, but there's heightened price sensitivity as the prevalence of high deductible health plans has increased awareness and increased out-of-pocket to patients, ongoing trend probably the last 5 to 10 years. And then increasing competition for ambulatory services, that front door through which pediatric patients enter a health system, either through the ED, through their primary care physicians. There's increasing competition, and so the importance of making costs of transparent in provider-based versus freestanding settings, for example, of out-of-pockets through ED visits versus urgent care or other mechanisms. Patients want to know how much it's going to cost, and they want to know how good you are at solving their problems. And so we're seeing health systems focus more in these areas. The second trend that I want to speak to briefly is the increasing focus on population health. So this has been an ongoing trend since, I don't know, probably at least 5 years or more. But population health management then offers opportunities in particular to improve care for children with special health care needs, so those that are medically complex. These are those categories, as you all know, that have a small proportion of the patients but a high proportion of costs. And so they offer the best opportunities for better coordination, for better care management, for better measurement of results, and the better opportunities to measure outcomes and reduce costs. So in particular, these models for innovative care coordination for children with medical complexity are becoming a focus through pilots, either with state Medicaid programs or sometimes with commercial health plans, and offer opportunities to reduce costs and facilitate seamless care and better outcomes for their patients. The third trend I want to highlight briefly is the influence of healthcare systems on pediatrics. We're seeing that larger systems that have a majority of labor and delivery services and maternal fetal medicine, perinatal care, and NICU care are becoming increasingly interested in performing pediatric subspecialty care and surgery, initially related to NICU care, but then moving beyond that, inpatient pediatrics and long-term care, in particular for those patients that require ongoing surgeries and ongoing care, moving through their lives until they become adults. And why is this? Well, there's a number of factors. There's demand for inpatient. There's a notable recognition of the high margins that freestanding children's hospitals have. These margins have been noted in many public forums. And then, of course, the ability to manage populations. So mothers to babies to children to adolescents to adults. So this is driving the development of pediatric services within larger systems. It's driving partnerships between children's hospitals and larger systems. And it's also driving partnerships around primary care and the development of primary care networks. The fourth trend on slide 12 relates to the measurement of return on technology investments. Many of you have seen large investments in technology over the past 5 years in particular, but 5 to 10 years for many of you. And the recognition that these platforms are not necessarily customized for pediatric health care, and so there's the need for optimization. That, as you can see in the graphic on the left side of the page, encompasses many different areas, including the governance and management, the relationship to staffing and training, the development of efficient workflows, customized solutions where necessary, and fundamentally relating to system optimization and the measurement of return on investment of these technology investments. So key questions include, have you been able to do this? And what is your system doing to optimize this? How is this impacting your physician work environment? Is it making them more efficient, less efficient, better able to manage and improve outcomes? The final trend that I just want to spotlight is around cost containment. So cost containment, what we're seeing is that this is coming from several high-profile reports noting that costs are extremely high in pediatric environments, and in some cases in large freestanding programs, freestanding children's hospitals. Traditionally, these are naturally higher because of the complexity, naturally, of patient care, the draw from larger regional areas, and the complex nature, less pressure in the past because of strong reputation and the ability to negotiate based on actual costs. And then fundamentally, expenses associated with being in academic settings. Many of you work within settings where you have learners, medical students, nursing students, other ancillary students, in addition to residents and fellows, large, robust fellowship programs that sometimes layer costs onto your environments. So pediatric systems have begun because of the influence of the market, healthcare insurers and larger systems that don't have the similar types of cost structures. There's been a larger focus on moving care to lower cost settings and exploring innovative models of care and fundamentally managing resources in a better way. So within these kind of high-level trends, then, we look specifically at the pediatric physician compensation environment, the next section. And I know many of you, from my experience doing these in the past, are interested in very specific data points. What's happening around pediatric subspecialty physician compensation and non-physician practitioner compensation? What's happening with their production? Are they becoming are they as busy as they've been in the past? Have we been able year over year to reduce wait times? Those very specific elements that fundamentally relate to how well we are paying our physicians and whether we're able to follow the market trends. And fundamentally, are their jobs changing? Are they becoming different? And so there's a couple of things I want to spotlight on this, and I'm going to pull in a few of the survey results as a segue into some more specific results that Angie's going to share. To start with, though, I think it's important to keep perspective. Physician compensation is really part of the larger framework of an integrated subspecialty physician network. The compensation plan in the lower right slice of the pie here, really, it's only part of this. So there's practice management, there's physician leadership, there's organizational structure, and then there's the fundamentals around how we get patients in and how we enable our physicians to be productive and able to manage patients better. So at best, the compensation plan is really a strategic enabler and ought to be thought of as a fundamental component, but not the only component, related to achieving our strategic objectives. On 16, then, really all of you are dealing fundamentally right now with conflicting challenges that are fundamental to both immediate and future success. Everyone is anticipating a shift to volume-based systems, from volume-based systems to value-based systems, I meant to say. However, the present really is fundamentally built on a fee-for-service model. Some of you have pilots. Some of you are having conversations with payers. Many of you are not, as payers, depending on the market, tend to be more focused on adult care and Medicare-based systems. However, we're managing this conflicting push and pull related to this shift. So, but I will say that nearly all systems are focused on becoming better at measuring and the relationship to the physician environment of a shift to value-based care. The next slide then highlights a few of those metrics. So we've noted over the past several years this gradual shift, but not a whole-scale, large-scale shift. But fundamentally, these components are in a couple of buckets down the left side of the page. Quality has been a measure that many of you have tracked over several years, but it's evolving. It's evolving as the presence of individual societies make more data available and come out with position papers about what we should be focusing on. Patient satisfaction is something that everyone is familiar with, that we've been measuring for a long time, but we do have some second-generation examples, and we're looking forward to third-generation examples, frankly, that will move us more towards a better focus on patient satisfaction. Of course, there are financial performance, and then finally citizenship components too, for which we have examples, but many of you are considering moving to second-generation and third-generation examples. The next slide highlights a trend that many of you track that we get a lot of questions about, and this is a high-level look at the investment per pediatric physician. It's a global look. So it's to start with, I'll say what it isn't. It isn't a generalized metric that can be applied to any type of pediatric surgical or subspecialty physician. It naturally varies. So it will vary based on the degree of Medicaid present, the fundamental benchmarks for a particular surgeon or pediatric or hospital-based physician, but offers a general trend over many years, which I think is why this is an important and interesting statistic of the investment in pediatric physicians. And we're seeing that number growing. As you can see over the past 4 surveys, that number is fundamentally growing. So very important to note this, indicating that the payment systems specifically for pediatric physician care is not matching the trend in compensation, the trends in compensation. Another high-level trend on the next slide is the proportion of at-risk compensation. I can remember 10 years ago, 15 years ago, where we saw very little at-risk for pediatric physicians, and we've gradually seen that shift. And you can see over the years in these graphs what that means on the left side, at least, and then fundamentally related to the type of physician on the right side of the graph. But we're seeing something like, as you can see, 21.7% overall as being variable compensation. Many of you still have pure salary-based compensation programs, but there are those that have high percentage of at-risk as well. So we saw that surge in the 2014 survey, and fundamentally we're seeing it, I think, follow the similar general trend that we saw prior to 2014, which is around a fifth, around 20%. That number naturally will vary depending on the proportion of general peds, medical specialties, surgical, and so forth. The next slide, fundamentally, I'll hit on these relatively quickly because we've got some more specific results to share, but work RVUs still remain the most common metric in incentive plans. Quality is now being measured by half of our survey members, but there are a number of others that are being measured as well, and in a small part at least being compensated on. So the alignment of these comp structures with organizational goals under these value-based payment models will need to emphasize these elements of both production and non-production. But fundamentally, we're not seeing a rapid shift from work RVUs and from production to other metrics at this point in time. The next slide highlights another high-level trend that I think relates to the previous slides, and that is the relationship of payer mix and reimbursement to the financial fundamentals that I described a couple of slides ago. Basically, these are stats that many of you, I think, are familiar with, that we're seeing that in freestanding children's hospitals, there's a higher proportion of Medicaid, and it's about half, and a lower proportion of commercial. We're seeing, as we have seen, the growth or the expansion of CHIP and CHIPRA and the expansion of exchange programs gradually reduce the number of uninsured. For many states, it's down to 0, basically. In some, there's still some proportion of uninsured, but very small now, and we're really talking about Medicaid and commercial insurance. Then fundamentally, that game of shifting rates or shifting costs, I guess, through the negotiation of rates. We're seeing that commercial reimbursement rates as a percentage of Medicare hovering in that 170 to 180% as a target, but actually achieving somewhere around 150% of Medicare across all survey participants. That's the right side of the graph. Finally, I'll say a couple of things about fair market value, because there is the emergence of some regulatory pressures related to how and how much we pay physicians. So we know fundamentally that benchmarks right now are less informative in a value-based setting because they're composed predominantly of physicians paid through fee-for-service models. And those structures were put in place between 2 and 10 years ago. So there are other factors and facts that we use to support fair market value, but there are also factors that may create some fair market value risk. The fundamental point here, I think, is that the public policy objective is really eventually to supplant volume-based payments with value-based payments, not to layer on additional costs. So where fair market value payments can be supported through production-based and volume-based systems, value-based systems will eventually replace but not be layered on to those payment systems. So I gave you a lot to think about here, and really intended this as more of a tee-up for some specific results that Angie will share now. And so without any further ado, I guess I will introduce Angie and ask her to go over some of our very specific results that I know you're all very anxious to hear.
Great, thanks, Ken. So I'm going to jump right into slide 24 and just provide an overview of particularly the growth of the survey. And it's definitely come a long way since the first survey kicked off in the 2006 timeframe. And now in 2015, we've wrapped up the 9th year of the survey and really have an impressive data set that's dedicated to pediatrics of nearly 7,300 physicians and advanced practice clinicians. Plus we have, as Maria mentioned, the organization level data for 48 children's hospitals and organizations across the country. And I think what's important here is that the reasons that ECG, which is first and foremost a consulting firm, started this survey are the same reasons that we continue to conduct the survey and grow the survey. And it's really wrapped around our clients and our members and their needs and really their demand for the most rigorous and accurate benchmarking resource out there around the compensation and production topics. We know that the results here are used for very specific activities within your organizations, for market assessments, for redesigning compensation plan packages for both physicians as well as those APCs, so your nurse practitioners, your physician assistants, and other mid-level providers. We know that it is utilized for evaluating and benchmarking productivity for physicians, both at the individual provider level and looking at the specialty as a whole. We do have many of our members who rely on our survey source to utilize in their fair market value assessments and opinions. People look at this for provider benefit benchmarking and design, market payer contracting strategies, and a host of other information around recruiting and retention. So what started out as really us filling a void in the market, which is to have a dedicated survey for pediatrics, has really evolved into a core service for ECG, as well as a reliable resource for our members and our clients on a variety of provider performance issues. On slide 25, for each of the organizations in the survey, we capture several demographic attributes, including the ownership of the physician group, their teaching hospital affiliation, the type of children's hospital or pediatric program that the physicians are affiliated with. So a freestanding children's hospital, say, versus a hospital within a hospital, as an example. We also capture data on the overall size, meaning the number of physicians in the group, and other key practice characteristics. And we summarized some of these 5-year trends related to those key key demographics in the graph on the left. We have 91% of our providers in the survey this year that are employed by a health system or hospital. And you can see that that number's increased over the last few years, and it's really reflective of broader market trends related to the hospital employment of physicians. 56% of our providers are affiliated with a teaching hospital, again, with pediatric programs being heavily invested in academics. That's not surprising to me. And 71% are affiliated with a freestanding children's hospital. The pie chart on the right summarizes where those 7,300 providers reside by region. So we have 37 states represented in our membership this year, and our goal is to always get to that magic 50-state number. When you look at slide 26, just to sort of tie into the region information that I just presented, there's a map where we've just pinpointed where the members of our survey reside, and the red triangles are the pediatric survey members, and the navy circles or ovals represent the membership in our national survey. So as Maria indicated earlier, we do have a national survey that really focuses on the adult provider compensation and production specialties, and we've been doing that survey for 16 years. So it's another well-established survey in the market. You can reference Appendix A. We've provided you a very specific list of every member that contributed data to our survey, so you guys might be interested to review that at your leisure. And I think that what's important to note about the pediatric survey is that as it's grown, we have maintained that loyal base of members, folks who value this survey from year to year, and the retention of members is in that graph on the right. We usually average from 75 and 80% of our members that return for the next year, and the typical member has been part of the survey for 4 consecutive years. So there is a lot of value in being a year-over-year member in that survey. On slide 27, this provides an overview of the various specialties. We did have 55 pediatric specialties represented in our survey this year. We have some high-level, or rather some select sample sizes in some of the larger specialties in the bar chart on the left. And in looking at really the distribution of providers in the survey, 55% came from various medical specialties, including general pediatrics in that group. And then 25% were from hospital-based specialties, 8% in surgical areas, and then 12% were APCs. So we did see the proportion of APCs increase this year compared to last year. Last year it was 9%. This year it's 12% of providers. And I think that's really a combination of things. Our members are realizing that we do collect and report on data for these types of providers, and so they're actually submitting that data to us along with their physician data. And I think the other thing that's happening in the market, we know the other thing that's happening in the market, is that your organizations are simply hiring and you employ more of these types of providers, particularly as you're growing your networks. On slide 28, and really this next section really focuses on some high-level trends in compensation, production, and benefits. So on slide 29 is when we get into some of the details. And when we look at the trends in compensation and production over the last several years, there are a few things that catch my eye on this slide. So the first is that compensation continues to increase overall, and it has every year of the survey. There was a 0.5% increase in aggregate this year compared to last year, and you can see that that is a slower increase or a smaller increase than in prior years. So the compensation is still going up, but the increases are definitely more measured from year to year. The second is that this is the second year in a row that work RVUs have declined. Granted, it's only a negative 0.7% shift from 2014 to 15, but I think what may be more telling is that when you look at this at the specialty level, about 75% of the specialties that we reported work RVUs on saw a decrease in their work RVUs this year. And for many of those, 2015 was the second year of decreased work RVU levels. And then the third thing I'll point out is that the gap, and if you look at the chart on the left, you can see this, the gap between professional collections and compensation is shrinking. So the impact of rising compensation and then falling collections is shrinking that gap. And for the past few years, the ratio of compensation to net professional collections has increased, which is not an improvement. That means that organizations are using a greater proportion of collections just to pay physicians. When you look at slide 30, and this is specific for hospital-based specialties, you can get some more detailed trend data. So for the first time in the history of this survey, compensation for hospital-based physicians actually went down. It decreased by negative 1.8% versus 2014 compensation levels. Work RVUs also decreased. This was the third consecutive year of work RVU decreases, and work RVUs in this subgrouping have decreased 5 out of the last 6 years. The only hospital-based specialties that didn't see those lower levels, those lower RVU levels, were emergency medicine and radiology. And many hospital-based specialties have struggled with flat or declining admissions since at least 2009. But the good news, I think, for these specialties is that in the latter part of 2014, when you look at the recent data, it suggests that those numbers could be rebounding in terms of admissions. We know that the flu season hit EDs hard in that latter part of 2014, as well as expanded Medicare coverage and eligibility that are bringing more patients to hospitals that are contributing to increased volumes. On slide 31, this specifically addresses the trends with medical specialties, and physician compensation levels for medical specialists increased 2.6% compared to 2014, with the majority of specialties in this group seeing a small increase over last year's levels. Work RVU levels were relatively flat. Well, they were flat. There was no change compared to 2014. And if you look at the trend there, this is the third time in the last 4 years where work RVUs for medical specialists have been unchanged or relatively flat. Again, this is taking all of those medical specialties and producing an overall result. So you can imagine there is significant variability when you peel the onion back and you look at that next layer down at the individual specialty level. When you do combine higher earnings and flat work RVU production, the result is an increase in the rate of compensation paid per unit of production. So compensation per work RVU increased more than 5%, again with significant variability at the individual specialty level. And finally, on slide 32, looking at the trends for surgical specialties, this picture is similar to what the medical specialists have experienced in terms of the compensation and production data. So compensation for surgeons went up by 2.8%, which again represents the largest rate increase among all types of physicians in the survey. And while work RVUs did increase overall in surgical specialties, that small 1.3% increase is really driven by the increased or the larger work RVUs in general surgery. Other surgical areas in this grouping actually saw decreases. So the other specialties saw decreases in work RVUs, really ranging from 0.5% down to a negative 2 to 2.5% decrease. And when I looked at, and that was intriguing to me, so when I looked at the CPT data for this subgroup for just those surgical areas where work RVUs declined, to understand what was driving that decrease, what I found is that the decrease is in part due to volume, so versus say acuity or mix of procedures. So there were actually fewer surgical procedures done compared to the 2014 CPT data, specifically fewer surgical procedures and fewer E&M visits. Looking at slide 33, we define overall benefit expenses to include the employer's cost of health benefits, life insurance, short and long-term disability costs, the retirement contributions of the employer or your organization, as well as rolling in the payroll taxes that you pay. So the overall cost of benefits decreased by 2% compared to 2014. And in 2015, it averaged $45,737 per physician FTE. And if you break down that expense by type of benefit, only retirement expenses increased compared to last year, and it really was a very small increase, hundreds of dollars up from last year. So the cost of providing the other benefits, and in particular health benefits, all went down. And remember, this data only captures the employer's cost of health benefits, and over the last several years, we have seen organizations shift premium expenses for medical costs to their providers, really as a means to control those overall provider expenses. And as a result of the overall decrease in benefit expenses, the benefits as a percentage of total compensation also decreased and averaged 17.2% of compensation this year. And when I look at slide 34, this gives a little bit more of a deeper dive into those indicators used in variable compensation plans. So as Ken spoke to earlier, we have between 21 and 22% on average a compensation is variable. And the table on the right really breaks out that 21.7% by the very specific indicator that's used, as well as the average compensation tied to that indicator. So overall, 10.3% of total compensation is determined by a physician's level of worker review production. And even though half of our members report using quality in their plans, which we saw earlier in the presentation, so 50% of our members are saying quality is a component in their physician compensation plans. When you actually look at the percent of total comp that organizations are tying to quality, it's still very low. It was 3% this year, but that is a growing number, as you can see if you look at that trend from 2013 to 15. So when we began reporting this data, even back before that 2013 survey, it was 1.6% of total compensation. Last year it was 2%, and now it's 3%. So we do think that as the revenue streams from payers continue to change from volume-based to value-based, you're going to see that number continue to grow. And overall, the pie chart on the right really shows you that there are three indicators that are really driving the variable compensation. So 90% of variable compensation is really derived from three indicators: work RVUs, provider profitability, and quality. So there are the pie chart on the left gives you the actual percent of variable compensation that's allocated to each of those metrics. And finally, just to talk about quality a bit more on slide 35, we last year, in 2014 actually, ECG began requesting from our survey members the provider level data for variable compensation that was earned as a result of achieving quality targets. So for those organizations that do have quality as part of their plan, we ask them to tell us how much each physician earned for that quality piece. And on the median was $15,391, and that was a median that was calculated from across 500 physicians. And I think what's important to note is that it is 1.5 times the median that was reported last year. So it's about the same number of physicians, but the dollars that are being earned are going up. Clinical quality compensation did increase for all types of physicians, and in particular, it doubled for medical specialists. And I think the thing that, kind of tying back to what Ken said earlier, is that measuring these non-production incentives, it continues to be a challenge, I think, for clients and survey members. It does require a very specific and significant investment in infrastructure, your data and reporting capabilities, and especially for those of you that are just beginning to link compensation with quality or really any other non-production-based measure. One of the most effective strategies is to really leverage what you're already collecting. So leverage the existing measures and utilize ones that you are already reporting and tracking as the foundation for establishing that incentive plan. And that really helps to mitigate any concerns about tying compensation to clinical outcomes and overall performance. And it's definitely a process to do that. And many organizations are using external clinical protocols as a starting point to measure quality. If you are looking at CMS hospital core measures, other internal protocols, and meaningful use would be another example of common measures that are used by organizations. So the last section here, section 6, is around a brief overview of ECGVault. And in the last couple of minutes we have here before Q&A, we have talked about it a few times throughout the presentation, but ECGVault is ECG's proprietary online benchmarking website, and all of the members of our survey do have access to this with a secure username and password. What it allows you to do is intriguing, though, because you're able to look at organization level, provider level, as well as market trending data of your provider's performance and benchmarks by specialty. So we have a couple of different ways that you can access information. We have dynamic reports, and we have static reports, and we have an organization statistics module. So it really is aimed at providing, the comprehensive look at provider performance and allowing you to access these dynamic reports, for example, in a way that you can create analyses that are custom to you. So within those dynamic reports, you do have the ability to look at specialty-specific trending, as well as look at some standard reporting. You can download benchmarks, and it's interesting because you're able to already create your reports with the data that you've submitted. So you don't have to go through a separate process to upload your data. It's all there ready for you to compare your performance for your physicians compared to the market. We also provide static reports, which give you those PDFs. They're in a PDF format, give you those benchmark tables. So if you're just wanting to look at the specialty-specific compensation and production benchmarks, by quartile for the survey, those are available to download for you. And then the last piece of ECGVault is the organization statistics module. So those 48 children's hospitals submitted data to us around a variety of topics. We ask about their benefit plans. We've asked about their compensation plans, how they are incenting providers, what are the metrics they're using. We have high-level revenue and expense data. All of those questions we wrapped into a market report and presented it in this module that you can navigate just through clicking through some of the buttons and choosing the questions that you'd like to report on. So it's, again, really a way to bring all the data straight to the end user so that you have that information around provider performance to really guide you as you're looking at, say, some benefit design or benchmarking your provider benefits, for example. Slide 38 really, again, just touches and blows out what is within those dynamic reports. You not only you get the current year, but you get the historical data as well, which is nice because it enables you in one of these reports, in our trending report, you can self-define the trend you want to create. So if you want to look at the 5-year trend, or if you want to look at a 10-year trend, you can do that just by specifying your start year and end year. And then the last piece of this around ECGVault I'll talk about on slide 39 is the Pediatric CPT code profiler. So one of the unique attributes of this survey is that we collect CPT level data from every physician and NAPC in the survey, and we calculate RVUs for everyone. And we do that for a variety of reasons. One is that we are able to utilize our methodology to calculate RVUs, and that ensures that everybody's data is calculated based on the same premise, the same RVU, the same year, the same version of the RVUs within that year. And it also gives us those building blocks, the CPT code level data, so that we can then turn that information into looking at, say, practice profiles of a specialty, or we can analyze the top performed CPT codes. We can look at within a certain code range for E&M services. We can look at how your individual providers compare in terms of that distribution of how many times they're billing a level 1 versus a level 3 versus a level 5 code. So it really provides you with some interesting ability to be able to do those very specific analyses and to compare your physician's data to the market without having to do any additional work. So with that, I will turn it back over to Maria, who can address some of the questions that have come in throughout the presentation.
Thank you, Angie. I'm sure our webinar audience joins me in thanking Ken and Angie for sharing their experiences related to our to the pediatric subspecialty market. And so let's move on to some of your questions. First, a reminder, please continue to enter questions in the question and answer pane on the right of your screen. I will ask as many questions on your behalf as time permits. And with that in mind, our first question, and hold on, I'm getting organized here, and I think this one may go to Ken. Ken, what are some of the indicators that an organization may be ready to change their compensation plan from one that's based on productivity to one that is incorporates quality or value-based metrics?
So is the first part of that question was what are the indicators?
No, what would give you, I'll paraphrase, how is a pediatric provider organization, how do they know when they should be looking at incorporating value?
Yeah, good question. Good question. Yeah, so I mean, first of all, I think if you're not, you should be, because the industry trend is to move towards that, and eventually payments will have some basis. They may not be large to start with, and those that don't have some system of measuring, tracking, and potentially rewarding will be behind. So I would say to everyone that you should be starting that conversation right now. Now, having said that, I do know that with many of you, with many of my clients, there's been this hurry up and wait a little bit mentality where, yeah, we approached our payers and they say that they're not interested. They don't want to talk about it. They're worried about the Medicare pilots. They're worried about the adult programs. There's certainly some of that going on. So in terms of actually flipping the switch, many of, as I think the data indicates, many of our survey participants are implementing quality-based metrics. And it's because of what they're anticipating coming down the road, because of what systems are doing with Medicare and with adult programs.
Okay, great. Thank you. And this question here basically dovetails off of that one. It says, what are the biggest challenges to implementing a value-oriented compensation metric? So once you've made that decision to implement value-based measures into your compensation plans, what kind of challenges are you seeing organizations have to address in successfully implementing these measures?
Yeah, that's a very good question. The first one obviously is measurement. So what is it we're measuring, and can we get agreement and acknowledgement that it's something that we can measure well, that we can measure accurately, and that we can measure longitudinally, that we can cover it over whatever period of time we need to. So we're often seeing programs where they pilot. They watch the data before actually including it into any type of compensation. So it's very important that you have that credibility. Otherwise, it loses its power as an incentive. If a physician or physician organization or physician leadership are not on board, then it loses its power. The second is, there's always this difficulty with making something very specific to an individual physician versus larger core metrics that you individually may not have a tremendous amount of influence on. So that's another conundrum that I think a lot of organizations are struggling with. How to balance that, making it meaningful to individuals and yet letting it, picking a metric that will track with overall strategic goals.
Okay, great, thank you. Here's a question that came in for Angie around the CPT code profiler. The questioner is wondering whether the profiler just contains data regarding the visit data around, E&Ms, or is there information in the profiler around surgical cases and surgical volumes for surgical subspecialties?
So it contains information for every CPT code built. So it is not exclusive to E&M codes. That is a piece of it. But when you run, for example, a top 50 report or top 25 report, you're going to get the top, if you look at a surgical specialty, you're going to get, the average number of surgeries, by code for your particular provider as well as for the market. So you get everything, and it's I think inclusive of everything that physician is billing.
Okay, great. Thank you. Here is a question from one of our listeners. How do you account for nurse practitioner accountability in an environment when they are a care extender to a physician, if they're sharing billable? So it sounds like if they're being used as an extender, how are you keeping them accountable? And Ken, I think
from a data perspective,
I think so. I think that they're trying to understand how do we track their productivity, or if they're being used as an extender, is it showing up in the physician data? That may be what.
Yeah. So that piece of it I can answer. We asked for the servicing provider, the rendering provider of the code. So you'll have two columns in the data. One's the billing provider, which, say in that example, would be the physician or the MD that's supervising, and the service or rendering provider is going to be your APC. Our data is collected based upon that rendering provider. So we are able to uniquely calculate the RVUs that are delivered specifically by that nurse practitioner. And then, there's, I think the other question around that maybe is how what they're doing impacts maybe physician compensation plans from a more, global perspective. And I don't know, Ken, if you want to comment on how you've seen your clients, look at the supervision of APCs or what they're doing, and how that impacts maybe how you would pay physicians who are supervising those APCs?
Yeah, it's a great question, because I think that probably the person that asked it, and many of you who are on the line, understand that many children's programs, the larger ones in particular, have added mid-level providers or advanced practice clinicians, or whatever vernacular you want to choose. It ranges from PAs to NPs to nurse anesthetists. Extenders have added them over the last 5 years in particular, as a way to alleviate the backlog of appointments, the time to next available appointments on the outpatient side, and also as an efficient way to staff on the inpatient side, because of the inability to recruit in a rapid and quick way because of shortages among the specialists. So that we've added a lot of these types of practitioners. We don't always, in my anecdotal experience, we don't always use them in the right way. And so in many places we're not necessarily always billing appropriately when we should be. And so I think there's a lot of effort that's being put into how we manage these types of professionals, number one, so organizational and governance and relationship to the physician organization. And then number two, how we make sure that we're working to the top of our license, to use a cliche. So, and in so doing, making sure or triaging, making sure that the the scarce and expensive physician resource is being used in the best way possible. So a lot of these conversations are happening, and Angie spoke to this very specific data point. I think I see this as an emerging area of study in the next several years, because there's an acknowledgement, I think, generally that we don't always use these folks in the best way that we could.
Thanks, Ken. There's time for one more question here. For those of you whose questions we were not able to respond to today, either Ken or Angie will reach out to you and follow up with you so that you can get that answered. So the final question for today, I think, is for Ken. Will productivity-based compensation ever really disappear?
Yeah, that's a crystal ball kind of question, so I'll answer it in a couple of ways. I think what we're seeing, I feel increasingly comfortable with the trending data that Angie presented, which shows that it's not disappearing. And then the question becomes, well, what would make it disappear? Well, the emergence of value-based payment systems, and when will that happen? So my general approach to this is it will gradually lessen and will probably gradually and then rapidly lessen, and rapidly directly linked to the emergence of payment systems from third-party payers. When that starts to happen, that's a watershed event. That's a turning the corner kind of event, and then production is not going to be as relevant. So will it ever disappear? No, because there's always going to be the need to reward folks who perform more work. However, it will not be as prevalent as what we see in the current, in the current profiles that Angie presented. So then the question becomes, well, when will that be? Well, I don't see it happening next year, the year after. I hear enough anecdotes about how quickly these conversations are moving that I think it's a several-year kind of conversation. But like I said, when it starts to happen, it'll start slowly and then happen quickly.
Great, thanks, Ken. Thank you, Ken and Angie. This concludes today's webinar. Please take a moment to complete the electronic survey upon exiting today's session. As stated earlier, for each completed survey, a $5 donation will be made by ECG to Doctors Without Borders. We hope you'll join us for other ECG webinars. Visit trends.ecgmc.com for more details or to register for a future session. Check back to the site regularly as more topics are posted. Thank you and have a great afternoon.